Cardiorheumatology pertains to the repurposing of agents traditionally used by the rheumatologist in the treatment of inflammatory joint disease, colchicine, allopurinol, methotrexate, and chondroitin sulfate, instead to attenuate the oxidative and inflammatory stress that underlies cardiovascular disease. In part 1, we discussed the benefits of colchicine in acute and chronic coronary disease. Colchicine lowers inflammation, and when you lower inflammation, you also lower oxidative stress. And when you lower inflammation, oxidative stress, you also improve endothelial function. And when you do these things, cardiovascular outcomes improve. Adding colchicine to standard medical therapy, aspirin, statins, and ACE inhibitors, decreases 3-year adverse event rate, unstable angina, heart attack, or stroke by 75%. Stated otherwise, 3 out of 4 patients who should have experienced an adverse event did not, simply because colchicine was added to their treatment program. Colchicine works by blocking NLRP3, an intracellular danger sensing and response system, a system that mediates plaque destabilization when white blood cells engulf crystalline cholesterol within the artery wall. Colchicine also inhibits NADPH oxidase, which when maladaptively activated generates excessive superoxide free radical, contributing to oxidative stress, which as you now understand leads to inflammatory stress and in turn to cardiovascular disease. Xanthine oxidase, covered in part 2 of our discussion, generates the lion's share of superoxide free radical in conditions such as metabolic syndrome, type 2 diabetes, coronary insufficiency, heart failure, and kidney disease. Allopurinol blocks xanthine oxidase, protecting us from this inappropriate and often overwhelming free radical storm. Thus, allopurinol is of benefit in these conditions. Oxidative stress leads to inflammation, and inflammation leads to oxidative stress. In these processes, nuclear factor kappa beta, our most powerful inflammation amplification system, is pathologically activated. In part 3, we will learn that chondroitin sulfate blunts nuclear factor kappa beta activation, explaining how chondroitin sulfate can be of value in conditions ranging from osteoarthritis to coronary insufficiency and psoriasis. Chondroitin sulfate has a second and probably more powerful effect in that it interferes with lipid trapping within the vascular wall. So let's begin our discussion of chondroitin sulfate in cardiorheumatology. We'll start with an epidemiologic study examining risk for heart attack in relation to how one's osteoarthritis is treated. This study was carried out in Spain, which utilizes a central record-keeping system, and we're going to look at 49-year-old Spaniards under treatment for osteoarthritis. We'll characterize these individuals in relation to their predicted. If you were hypertensive, a smoker, or a diabetic, you were considered at high risk for cardiovascular disease. And we'll look at the type of osteoarthritis therapy. Non-steroidal agents such as ibuprofen, or agents such as paracetamol, which is like Tylenol. Cisadoas are symptom-remitting, slow-acting drugs that work in osteoarthritis, and this would be chondroitin sulfate and or glucosamine sulfate. Now, we're going to look at your relative risk of having a heart attack in relation to how your osteoarthritis is treated. If you were felt to be at low risk for cardiovascular disease and you took a non-steroidal, your risk did not increase. However, if you were at pre-existing high risk for myocardial infarction due to the possession of risk factors, diabetes, smoking, hypertension, and you took a non-steroidal, your risk rose by 28%. If you took the non-steroidal for over a year, your risk rose by 43%. If you were at pre-existing high risk for cardiovascular disease and took the non-steroidal for over a year, your risk rose by 80%. Thus, we will consult moderation when we use non-steroidals in the treatment of osteoarthritis, particularly if you have risk factors for cardiovascular disease. Paracetamol, which is the Spanish version of Tylenol, its use was not associated with an increased risk. However, the use of chondroitin sulfate and glucosamine sulfate, patients who took those agents experienced a lower relative risk of heart attack. This was not a randomized double-blind trial, but it suggests that we should be cautious with non-steroidals while there might actually be a therapeutic benefit when the agents such as chondroitin sulfate are used in the treatment of cardiovascular disease. And this, of course, piques our interest in the use of chondroitin sulfate in cardiovascular disease. This and other studies have shown us that chondroitin sulfate is of documented value in atherosclerotic vascular disease, psoriasis, and osteoarthritis. Chondroitin sulfate is likely of value in inflammatory bowel disease, other systems, other disease states characterized by Th1 and Th17 immune dysregulation, and in gout. How does chondroitin work? It inhibits translocation of nuclear factor kappa beta. LDL and oxidized LDL binding to intimal and macrophage proteoglycan is blunted. Chondroitin may provide an anticoagulant effect, and in some models, it lowers lipids. What is the risk? It appears to be nil. There's no effect on insulin sensitivity. Some studies suggest that glucosamine sulfate leads to insulin insensitivity. None show this with chondroitin. Chondroitin is not metabolized in the liver through the P450 system, so it's not going to interfere with the metabolism of other nutraceuticals or drugs. The key question, which source of chondroitin should we use? Chondroitin is not synthesized in the lab. It's extracted from animal cartilage. Bovine, that's cattle; porcine, pig; marine, that would be shark or whale. We don't know what the best source is and what is the best dose. The studies suggest that the therapeutic dose would be somewhere between 750 and 1500 milligrams twice a day, and we don't, and which vendor is going to provide us the best quality product. Now, atherosclerosis begins when lipid particles infiltrate the artery wall at signs of intimal activation and endothelial dysfunction. That's not necessarily a problem because the lipids can swim out of the artery wall if they're not needed, unless they're retained. And lipids are retained when they are minimally oxidized by phospholipases, causing them to clump up, or when they bind to proteoglycan within the artery wall. And chondroitin sulfate within the proteoglycan binds to and retains the lipids. These minimally oxidized retained lipids can then be fully oxidized by free radicals generated by the other cells of the artery wall, creating oxidized LDL, which initiates the Th1, Th17 immune response that drives atherosclerosis. Lipids are not a problem until they're retained and oxidized. Proteoglycan, chondroitin sulfate, is involved in binding to and retaining lipids within the artery wall. Over the years, the plaque progresses with the progressive infiltration of mononuclear immune cells, and in this process, we see an increased generation of chondroitin sulfate proteoglycan within the artery wall. Proteoglycan chondroitin sulfate is generated by all the cells of the intima, and it's also generated by macrophages and mediates binding of LDL and oxidized L to the macrophage. As the disease progresses, we get progressive immune dysregulation. Th1 and Th17 cytokines are elaborated. Regulatory cytokines are decreased. As we go from non-coronary chest pain to stable angina, unstable angina, heart attack, the percentage of our immune cells that are skewed towards inflammation, Th1 and Th17 increases. Finally, we tip over with too much oxidative stress, and we have the bonfire, plaque rupture, which is an oxidative inflammatory bonfire. Of course, we don't want our patients to get to that point. So we're going to deal with the causes of cardiovascular disease, the abnormalities in vascular biochemistry and cell biology that cause cardiovascular disease. We want to focus on your risk factors. And central to this is oxidative inflammatory stress. We understand that atherosclerosis involves a maladaptive response of the acquired immune system to what it perceives as infection of the artery wall with oxidized lipids. We also now understand that cells of the innate immune system will regard crystalline cholesterol within the artery wall as a sign of danger, and that will initiate an inflammatory response that will cause plaque destabilization. Oxidative stress and inflammatory stress are the key driving forces. We talked about nuclear factor kappa beta, our most important inflammation amplification system. When our cells experience threat, when their receptors for cytokines and angiotensin II and bacterial wall lipopolysaccharide are activated, a chain reaction of serine kinases occurs, causing us to degrade the inhibitor of kappa beta, allowing nuclear factor kappa beta to translocate to the nucleus and code for inflammatory mediators and cytokines. Oxidative stress per se, manifested by hydrogen peroxide, will lead to nuclear factor kappa beta translocation because Mother Nature assumes that oxidative stress is a sign of infection. Oxidative stress leads to inflammatory stress, endothelial dysfunction, immune dysregulation, hyperlipidemia, and hyperglycemia because oxidative stress is regarded by Mother Nature as a sign of infection. Now, our joints will also experience inflammation in response to joint trauma. These inflammatory cytokines will be generated, and we will generate fibronectin and EMFs, extracellular matrix fragments, that will lead to activation of nuclear factor kappa beta to generate inflammatory mediators. And we can block nuclear factor kappa beta in the joint with chondroitin sulfate. Thus, chondroitin sulfate is of value in joint disease. And if we can block nuclear factor kappa beta in joint disease, we can block nuclear factor kappa beta throughout the body. Thus, chondroitin sulfate is going to be of value in multiple inflammatory conditions. Let's get back to atherosclerosis. Atherosclerosis begins when LDL, LPA, and remnant particles traverse the endothelium at sites of endothelial activation, sites of endothelial dysfunction and thickening, which is not a problem because every cell of the intima has an LDL receptor. LDL is food. All of our cells need LDL. The problem will occur when these particles become trapped within the intima and then they cannot swim out by enzymes such as lipoprotein lipase, phospholipase A2, phospholipase D. Now, lipoprotein lipase is found on the vascular wall and within the artery wall. On the vascular wall, lipoprotein lipase breaks large lipid particles into small lipid particles, making it easier for them to wiggle into the artery wall. Lipoprotein lipase within the intima, within the artery wall, mediates binding of LDL to proteoglycan. Proteoglycan is also generated by the macrophages, and that is used to pull in and absorb the LDL particles. What is LDL? It is a sac composed of apolipoprotein B1 protein containing a lipid core of cholesterol and triglycerides, and it's studied with phospholipids. And the rheologic characteristics of the LDL relates to the quality of its phospholipids. Now, it would be great if all the phospholipids in the LDL was 1,2-dilinylenoyl phosphatidylcholine. That's essential phospholipid. That's medicinal phospholipid that we use to treat cardiovascular disease. Here, the second and third carbons of the phosphatidylcholine backbone contain linoleic acid. But in our patients, in Western patients where we follow a poor diet rich in dairy and meat, we're more likely to have arachidonic acid in the second position. Phospholipase A2 breaks this bond, creating lysophosphatidylcholine. The presence of lysophosphatidylcholine in the vascular wall is inflammatory. It causes the endothelial cells to activate and elaborate adhesion molecules to pull white cells in. Arachidonic acid is released, and it's going to be metabolized through the eicosanoid pathway into the deleterious prostaglandins of the 2 series and leukotrienes that mediate inflammation and atherosclerosis. Now, when these phospholipids are modified and oxidized on the LDL particles begin to clump together. They stick together to a clump, and then they bind to proteoglycan, chondroitin sulfate proteoglycan within the vascular wall, and they're now stuck. They cannot swim out, and they can be subjected to further oxidative modification. And we talked about what a free radical is. It is an atom with 1 as opposed to 2 electrons in its outer shell. It will quench its thirst for an electron by snatching an electron from an adjacent atom, creating a new free radical. A chain reaction will occur, damaging the cell, damaging the organ, and this mediates atherosclerosis and all of our other age-related conditions. And enzyme systems within the vascular wall will generate free radicals, and this will be amplified by mononuclear cells that mediate inflammation, and heavy metals and organic pollutants, of course, add to oxidative stress. So we don't want our lipids to become oxidized because when we have high levels of oxidized LDL, that is associated with an increased risk for cardiovascular events. It's associated with an increased IMT. Lipid oxidation drives atherosclerosis. So this LDL is getting trapped on the proteoglycan, which contains chondroitin sulfate and other disaccharides. What is proteoglycan? This is an electron microscope picture of proteoglycan. Here's a schematic. There is a backbone of hyaluronic acid to which is attached core proteins, to which is attached monotonous repetitive units of disaccharides, two sugar molecules put together, such as chondroitin sulfate, keratan sulfate, or hyaluronic acid. Now, there are 4 types of proteoglycans. They're very important within our physiology. There are intracellular proteoglycans that form up a scaffolding upon which much of our biochemistry occurs. Proteoglycans on the cell surface mediate cell-to-cell communication. Chondroitin sulfate on the cell surface of the macrophage mediates lipid trapping and incorporation by the macrophage. There can be paracellular and extracellular proteoglycan. All the cells of the INTMA, the endothelial cells, the macrophages, the vascular smooth muscle cells, will elaborate proteoglycan that forms up the matrix of the vascular wall, and within this chondroitin sulfate proteoglycan matrix, LDL particles will be trapped. Glycosaminoglycans are the disaccharides that make up proteoglycan, such as chondroitin 6 sulfate, keratan sulfate, heparin, dermatan sulfate, and hyaluronic acid. Now, heparin we use as a blood thinner. You can see that its structure is quite similar to that of chondroitin sulfate. These molecules differ basically in the positioning of sulfate groups and carboxyl groups. And you can see heparin has multiple sulfates, which is why it is an effective anticoagulant. We'll see that chondroitin sulfate, which has a few sulfate groups, has some anticoagulant activity as well. Now, let's talk about the naming scheme that we use for chondroitin sulfate. It's composed of repeating units of glucuronic acid and N-acetylgalactosamine bound together. And chondroitin sulfate A involves sulfation of carbon 4 of the N-acetylgalactosamine sugar. Chondroitin sulfate C, the sulfate molecule is on carbon 6. Chondroitin sulfate D, the sulfate molecule is on carbon 2 of the glucuronic acid. Chondroitin sulfate E involves sulfates on carbons 4 and 6 of the galactosamine sugar. A shorthand for chondroitin sulfate A, which is chondroitin 4 sulfate, is delta di 4S, which we obtain from bovine sources and from whale. Here again, you have the sulfate group on the 4th carbon. Delta di 6S is chondroitin sulfate 6, where you have the sulfate on carbon 6. You get that from bovine sources and shark. Disulfates would be delta di 4,6. This refers to a disulfated chondroitin sulfate that has sulfates on both carbon 4 and carbon 6. That's the naming system. And again, these are repeating disaccharide units. The structure of chondroitin sulfate, a glycosamine glycan, you have the core protein to which are attached the chains of the repetitive glycosamine glycans. Now let's look at an animal study of chondroitin sulfate in atherosclerosis. Squirrel monkeys are susceptible to natural atherosclerosis. As a general rule, animals do not develop atherosclerosis, but squirrel monkeys, like man, is susceptible to atherosclerosis in their native environment. So we're going to take these squirrel monkeys and assign them to 1 of 4 treatment groups. One group gets standard diet of prairie monkey chow. Another group gets 78% chow supplemented with 2% cholesterol and 20% butterfat, and this diet will produce atherosclerosis in this animal model. The third group gets the atherogenic diet and subcutaneous saline is a control group. The fourth group is on the atherogenic diet, and they receive chondroitin sulfate A subcutaneously 10 milligrams a day. You're going to examine their aorta at 9 months and rate plaque deposition on a 0 to 4 scale. 0 is no visible lesions, 4 is marked atherosclerotic changes. The animals on the chow diet have low-level atherosclerosis. Again, this animal is susceptible to natural atherosclerosis. The animals on the 2% cholesterol, 20% butterfat diet, their plaque score was 2. They were filling up with atherosclerosis. The animals on the bad diet that were treated with chondroitin sulfate A had far less plaque. Chondroitin sulfate A not only protected you from atherosclerosis due to the bad diet, it protected you from the native atherosclerosis that you would get on the higher quality Purina monkey chow diet. This is what the aorta looks like in a normal molecule. It's this white glistening surface. This is the aorta of an animal that was on the high cholesterol diet. Here you have the high cholesterol diet and heparin, which is a glycosamine like chondroitin sulfate. There's some attenuation, but the best result was when you had the high lipid diet and the animals were fed chondroitin sulfate. There's very little atherosclerosis. So chondroitin sulfate blocked atherosclerosis in relation to a high lipid atherogenic diet in squirrel monkeys. Now here we're going to take human adult intimal tissue in tissue culture. So we're going to get cells of the intima. These would be endothelial cells, vascular smooth muscle cells, other cells of the vascular wall in the basal state. And then we're going to load them with serum lipids and lipoproteins that bind to chondroitin sulfate proteoglycan and stain them for fat. And you can see that there's lipid uptake. The lipids are trapped and they're stuck in by the intimal cells. Then you'll incubate these cells with chondroitin sulfate A, and you can see that all the lipid washed out. This is because the lipids, the LDL is binding to chondroitin sulfate in proteoglycan within the intima, and if we add an exogenous chondroitin sulfate, we're going to interfere with that binding and wash all the lipids out. Well, will this work in humans with coronary disease? Let's look at chondroitin sulfate A and or chondroitin sulfate C in Japanese atherosclerotic patients with stable coronary disease. 32 Japanese patients, age in the mid-70s, their cholesterol is above 200. They're randomized to a 4-year treatment program that would involve 7 receive chondroitin sulfate A, that's chondroitin 4-sulfate, 1.5 grams TID, that's 3 times a day. 9 received chondroitin 6-sulfate, 1.5 grams 3 times a day. 9 received a mixture of chondroitin sulfate A and C. 9 received a placebo. 21 patients in the practice that were under contemporaneous care were observed as another control group. They didn't receive placebo. They all were treated with a diet of 1,500 calories a day, no drugs except for reserpine to keep their blood pressure below 160/90. This dates the study. Reserpine is a very old antihypertensive agent that I've actually never used. So this paper is about like the 1970s. You're going to look at thrombus formation time utilizing the Chandler's loop methodology, which I'll discuss at 13 months. You're going to record mortality over a 4-year follow-up period. Now, chondroitin sulfate A, they harvested that from whale cartilage. It was predominantly 4-sulfated. 80% was 4-sulfated, 20% was 6-sulfated. Now, this material is not made in a laboratory. It's an extract from animal cartilage, so you're never going to get 100% 4 or 100% 6. But chondroitin sulfate A is predominantly 4-sulfated. Chondroitin sulfate C was obtained from shark cartilage. It was predominantly 87% 6-sulfated, 13% 4-sulfated. They differed in their molecular weight. How long were the chains? So chondroitin sulfate obtained from different sources will differ in the degree of sulfation, where the sulfate group is placed, and the molecular weight, the size of the molecule. So here we have chondroitin sulfate that looks an awful lot like heparin. We know that heparin's a blood thinner, and the Chandler's loop methodology is something I've never used. You take blood, you put it in this device and measure how long it takes to form a clot. If thrombus formation time is prolonged, that means that an anticoagulant was added to the system. So you can see that in the control situation, a clot formed in 16 minutes with chondroitin sulfate A. It was 18.3 minutes. Chondroitin sulfate C, 20.3 minutes. At 18.2 with chondroitin sulfate A and C. So chondroitin sulfate has some anticoagulant effect. Not as strong as heparin, but it has some anticoagulant effect. Okay, what effect did chondroitin therapy have on outcome? 24% of the chondroitin sulfate treated subjects, 6 to 25, died over 4 years. Their average age at death was 84 years. One had a heart attack, one had coronary insufficiency, one had apoplexy, which I think refers to stroke, one with a drug allergy, one from old age, one from weakness following surgery for prostate cancer. Now, 43% of the controls that did not receive chondroitin sulfate died over 4 years, and they died at a younger age, 77 years. One had a heart attack in relation to alcoholism, 3 had coronary insufficiency, 1 died from alcoholism, 1 from softening of the brain, 1 from pneumonia, 2 from age-related diseases, and 4 from cancer. So the outcome was much better in the patients that received chondroitin sulfate. They were less likely to die, and if they did die, they died at an older age. Short-term effect of chondroitin sulfate A and chondroitin sulfate C in stable coronary disease. 31 Japanese atherosclerotic patients with ST depression on their EKG. This is the ST segment. When it's down from the baseline, that suggests that you're suffering from an insufficiency in blood flow. There's not enough oxygen. You can't make ATP. You're having chest pain. Your EKG manifests this supply-demand mismatch. So you do the baseline tracing, administer IV, 3 got chondroitin sulfate A, 5 milligrams per kilogram, 28 received chondroitin sulfate C, 10 to 20 milligrams per kilogram. Why they received more chondroitin C than chondroitin sulfate A, the authors did not elaborate on that. You're going to repeat their EKG periodically over 180 minutes. The 3 that got chondroitin sulfate A, nothing happened. But 8 of the 28 that received chondroitin sulfate C demonstrated an improvement in their EKG, ST, and T wave findings. Here you can see there's ST sagging and scooping at baseline. You treat this individual with chondroitin sulfate C, you can see that it resolves. Several hours later, it will return. So there was an acute effect of chondroitin sulfate C on coronary blood flow. So ischemia was relieved. Exactly how this worked, they weren't sure, but it showed a beneficial effect. 31 Japanese atherosclerotic patients with ST depression on an EKG. 5 undergo the master's 2-step. Now, when we are evaluating you in the office, we do a treadmill stress test. You walk on a motorized treadmill. In the olden days, the master's 2-step was used. You'd walk up and down, back and forth on this 2-step step ladder, and we would see how far you could go and at what point you experienced chest pain. I had a master's 2-step carried to myself. This is a good story. I'm a freshman in college, doing freshman biology, and we're dissecting frogs and putting electrodes in their muscles and watching them twitch. And then we moved on and did single lead EKGs on ourselves. We put an electrode in each wrist and did the EKG. And on mine, it showed 1st-degree AV block. In other words, there was a delay between transmission of the atrial impulse from the SA node in the atria to the ventricles. And this is not a problem in young people, but the professor was kind of worried, and he said, you know, at Christmas break, you ought to see a doctor. So I go home and tell my dad, who's a pediatrician, about it. He refers me to his buddy, the internist, who's in the next office. Now, this guy was a notorious overutilizer. He would have a hospital census of 60 to 80 patients, and he'd see them every 2 to 3 days. Otherwise, the nurses took care of them. If you needed a barium enema, he would admit you for 2 days. You'd have the barium enema, then you would go home. So this guy made an awful lot of money, and he didn't do a whole lot of work, and he kind of ruined it for the rest of us. And if you live in Toledo, Ohio, you may know the doctor I'm referring to. He's long since retired. But anyways, my dad referred me to his buddy, the overutilizer, so he decided to do a stress test on me. Now, this really should have been ignored in a young, healthy, athletic person. 1st-degree AV block's no big deal, but he, being the overutilizer, recommended that I undergo a master's 2-step, and I passed it. I'm happy to tell you, and I'm still alive at age 62, and I'm still running. But anyways, they did the master's 2-step on these 31 patients at baseline, and then 30 to 180 minutes following intravenous chondroitin sulfate. 4 out of the 5 showed an improvement. So there was an acute improvement in coronary blood flow with intravenous chondroitin sulfate C. 31 Japanese atherosclerotic patients with ST depression on their EKG. You're going to measure baseline thrombus formation time, 6 received chondroitin sulfate A, 12 get chondroitin sulfate C. This is kind of a busy slide, but it shows that chondroitin sulfate A had some anticoagulant effect at 60 to 120 minutes. Chondroitin sulfate C had appreciable effects between 30 and 180 minutes. So there's an anticoagulant effect. In rabbits, intravenous chondroitin sulfate A or C, 100 milligrams per kilogram IV, prolonged the prothrombin time by 12% and 18%. The prothrombin time is a measurement that we would use to assess the degree of anticoagulation you're experiencing if you take warfarin or Coumadin. And here they also use the Chandler's loop thrombus formation time, again showing an anticoagulant effect. So chondroitin sulfate has an anticoagulant effect, and it appears to acutely improve coronary blood flow, and this might attenuate angina, and it might improve your EKG. What about any effect of chondroitin sulfate on lipids? 30 atherosclerotic patients that had had a stroke, baseline assessment, divide them into 3 treatment groups. Chondroitin sulfate A, 4.5 grams per day for 4 weeks, 6 grams a day for 18 weeks. Chondroitin sulfate C at the same dosing regimen or no intervention. In the control group, the cholesterol bounced around a little bit, but it really was unchanged. With chondroitin sulfate A and C, there was a net reduction in cholesterol that was persistent. How does chondroitin sulfate lower lipids? Well, as we're going to learn, chondroitin sulfate blocks nuclear factor kappa beta translocation. If we do that, we block inflammation, we block oxidative stress. We know that oxidative stress and inflammation upregulate HMG-CoA reductase to make cholesterol, so by providing an anti-inflammatory effect, chondroitin sulfate appears to have some benefit in cholesterol control. Chondroitin sulfate and clot thrombus formation, 30 atherosclerotic patients with a stroke, divide into 2 treatment groups, chondroitin sulfate CIV or saline IV, evaluate the Chandler thrombus formation time, again, a mild anticoagulant effect with chondroitin sulfate. Lester Morrison was a doctor that I really wish I could have had the opportunity to interact with. I think Lester Morrison was the first integrative cardiologist in the United States. He used phosphatidylcholine to treat cardiovascular disease, and he was the practitioner that made us aware of the benefits of chondroitin sulfate in cardiovascular disease. He wrote 2 books, Coronary Heart Disease and the Mucopolysaccharides, which is another term for glycosaminoglycans, and a popular book, Dr. Morrison's Heart Saver Program. These books are out of print. I'm going to track them down, and I'm going to read them. And I wish I would have known about this in the past. Dr. Gary Gordon mentioned the benefits of chondroitin sulfate when I was beginning to learn integrative cardiology 20 years ago. I could not accept that a nutraceutical that was good for the joints would be good for the heart, but I should have listened to Gary. But anyways, better late than never, and now we can utilize Lester Morrison's work to utilize chondroitin sulfate in the treatment of our patients with cardiovascular disease. So this is Morrison's most important study of chondroitin sulfate A in stable coronary disease. 120 patients with stable coronary disease, abnormal EKG, 28 with prior heart attack, 79 with angina, mean age 66. You do the baseline assessment, divide them into 2 treatment groups. They were not randomized, but it was an alternate day group assignment every other day, matched for age and clinical condition. This was not a $30 million multi-center randomized double-blind study. This was a group of doctors doing basic research in their office as best they could. And even though it wasn't a $30 million study, it still gives us the information that we need. So all prior therapies were continued. This was in 1969 when I was in 8th grade. So therapy then was different from what it is now. They made their own chondroitin sulfate A. They obtained cattle trachea from a slaughterhouse and extracted the chondroitin sulfate A, so they made their own. 60 of the subjects did not receive chondroitin. 60 received 1.5 to 10 grams per day of chondroitin sulfate A. He started at 10 grams a day and decreased at different time intervals to a maintenance of 1.5 grams per day. Periodic reassessment, the mean follow-up of the first paper was 2 years. Adverse event rate. There was 1 fatal heart attack out of 60 patients on chondroitin, 4 in the control group. Non-fatal heart attacks, unstable angina occurred only in the controls. So only 1 out of 60 patients on chondroitin sulfate had an event. Only 44 out of 60 patients in the control group were event-free. So over 2 years, chondroitin sulfate was remarkably effective in decreasing cardiovascular event rate. So he ran it out to 2.5 years. You see the same thing. There's 21 events in the controls, 3 events in the chondroitin patients. Over 4 years, total cardiovascular event rate, 60% with the controls, 10% with chondroitins, fewer heart attacks. There were no non-fatal heart attacks with chondroitin, less unstable angina, less coronary ischemia. So over 4 years, adding chondroitin sulfate to standard therapy in 1969 was associated with a profound reduction in cardiovascular event rate. How did it work? Morrison hypothesized that chondroitin sulfate helped by providing a lipid clearing effect, an anti-inflammatory effect, an antithrombotic effect. It stimulated cellular metabolism, tissue repair, regeneration, increased fatty acid turnover, had an anti-allergy effect, and stimulated collateral circulation. These were his hypotheses to explain the marked benefit that his subjects received with chondroitin sulfate. Now let's shift gears a little bit and talk about chondroitin sulfate and urate-induced inflammation. We're going to take activated macrophages. These are monocytes stimulated via incubation with a mitogen 4-bol ester. So these are activated macrophages, as you would see in the vascular wall in a patient with atherosclerosis. You're going to incubate them with monosodium urate crystals, uric acid crystals, with or without bovine chondroitin sulfate, with or without a caspase-1 inhibitor. Caspase-1 would inhibit NLRP3. You're going to record the elaboration of cytokines associated with gouty inflammation. Now, we understand that gout involves two-step activation of NLRP3. First, there needs to be low-level nuclear factor kappa beta activation to make pro-interleukin-1 beta, pro-interleukin 18. And this could be an infection, a fever, a night out in the town to activate nuclear factor kappa beta. Then there's going to be frustrated phagocytosis of uric acid crystals. These mononuclear cells will engulf the crystals of uric acid. They can't digest them because they're not bacteria, they're rocks. The phagolysosome will fall apart, releasing cathepsin, generating free radical mediators, and that causes NLRP3 to come together and make caspase to convert the inactive pro-cytokines into the active cytokines, and then we have high-level nuclear factor kappa beta, and then we have the oxidative bonfire, which in the joint would be acute gout. Now, so we've got these activated macrophages, and we're going to incubate them with monosodium urate crystals, and they're going to phagocytose the crystals, and with this frustrated phagocytosis, we're going to have activation of NLRP3, and we're going to have an inflammatory storm. So we're going to record the elaboration of cytokines associated with gouty inflammation. 24-hour incubation of these macrophages with increasing levels of urate crystals. So if you look at interleukin-1 beta, at baseline, it's at the normal range. If you incubate with increasing concentrations of uric acid, you're going to activate NLRP3. You're going to make interleukin-1 beta. This is something that you understand based upon our first presentation. Now, 6-hour incubation with 20 milligrams per deciliter of urate and increasing levels of a caspase inhibitor. So if you incubate the mononuclear cells with uric acid, you're going to get a whole lot of interleukin-1 beta. But if you add in a caspase inhibitor to basically knock out the working end of NLRP3, you won't convert pro-interleukin-1 beta to interleukin-1 beta. You're going to knock out inflammation. This, again, is telling us that uric acid crystal-induced interleukin-1 beta generation is NLRP3 inflammasome dependent. Okay, so now for incubation with increasing levels of chondroitin sulfate, so the macrophages are incubated with chondroitin sulfate, and then you'll stimulate them with uric acid and look at the level of inflammatory cytokines that are elaborated. So if the mononuclear cells are not exposed to uric acid, you have a very low level of interleukin-1 beta elaboration. If you expose them to uric acid, you're going to get a whole lot of interleukin-1 beta, But if they're pre-treated with increasing doses of chondroitin sulfate, interleukin-1 beta is no longer elaborated. So chondroitin sulfate had a very powerful anti-inflammatory effect in these mononuclear cells that are exposed to uric acid. The same thing with tumor necrosis factor alpha and interleukin 18. So chondroitin sulfate is providing an anti-inflammatory effect. How is this working? Well, chondroitin sulfate and nuclear factor kappa beta. Chondroitin sulfate blocks translocation of nuclear factor kappa beta. So step 1 is blocked. Colchicine would block step 2. So you could, if you want to prevent gout, you could block step 1, you could block step 2, or you could block both. Chondroitin sulfate provides an antioxidant effect, neutralizing hydrogen peroxide. Hydrogen peroxide promotes translocation of nuclear factor kappa beta. There are 3 major serine kinases that promote degradation of ICPA to promote nuclear factor kappa beta translocation. 2 of these, P38 mitogen activated protein kinase and extracellular related kinase 1, 2, are blocked by chondroitin sulfate. Chondroitin sulfate blocks translocation of nuclear factor kappa beta. Now, let's talk about chondroitin sulfate in osteoarthritis. Now, these chains of proteoglycan with chondroitin sulfate have carboxyl and sulfate groups that attract water. So if we have chondroitin sulfate in our joint, we hydrate the joint. That provides cushioning from the joint. This is why we use chondroitin sulfate to help prevent osteoarthritis. That's one of the mechanisms. And the second is that it blocks inflammation by blocking nuclear factor kappa beta. There's this really cool book called Born to Run that talks about running and whether running is a normal behavior for humans. It focuses on a society of indigenous people that live in caves between mountains in Mexico, and it is part of their culture to run all the time. They run 20 miles a day. So one of the authors went to meet these people to understand why they are such good runners and why they run. And then they talk about the development of primitive man in Africa. Consider primitive man evolving on the savannas in Africa, and primitive man would need to run down his dinner. We would hunt in packs, and we would chase zebras and gazelles and other creatures. So one of us would sprint out after the animal would take off. The animal can run faster than we can, but it would get tired. And then the lead runner would drop back. Another member of the hunting pack that had been jogging would sprint and chase down the animal. And all the human runner hunters would take turns sprinting after the animal and then resting. Well, the animal didn't have a chance to rest. It would eventually become exhausted and collapse, and we would run up and we would kill it and we would eat it. And so the idea was that we were born to run because this is how we would obtain our next meal. So this would be kind of traumatic on the joints, wouldn't it? So there's going to be some joint damage, and extracellular matrix fragments and fibronectin will be elaborated. Inflammatory cytokines would be elaborated, and nuclear factor kappa beta would translocate to the nucleus that night after the hunt, and that would generate matrix metalloproteinases that would degrade these fragments and make molecules such as PGE2 that causes inflammation and pain to remind us not to hunt for a few days until you have a chance to rest and restore. So periodic exercise causing joint inflammation is not maladaptive. The problem we get into if we would exercise every day, or if there's undue trauma on the joints because you're working with power tools, or there's some sort of repetitive activity, or you're wearing poor footwear, you've got chronic trauma in the joint, you're going to get chronic nuclear factor kappa beta translocation, chronic inflammation, and this will damage the cells of the joint, it will damage the cartilage, it will damage the subchondral bone, and then you're going to get cartilage loss and bone loss and osteoarthritis. But chondroitin sulfate will help here by blocking nuclear factor kappa beta translocation, blunting inflammation, and by producing hydration and resiliency of the joint structure, particularly the cartilage. So chondroitin sulfate and osteoarthritis. So the cells within the joint, the the somatic cells, such as the synoviocytes, and there may be mononuclear cells, monocytes, that will respond to systemic threat and local threat with nuclear factor kappa beta. This can be blocked with chondroitin sulfate. So chondroitin sulfate is bioavailable. 15% will be absorbed. It will enter the joint tissue. It will support proteoglycan production to hydrate the joint, but more importantly, it blocks nuclear factor kappa beta translocation. Osteoarthritis is not just a wear and tear traumatic phenomenon. It is a wear and tear traumatic phenomenon and an inflammatory phenomenon, and we can block the inflammation with chondroitin sulfate. Well, if we can block nuclear factor kappa beta and help in joint disease, we can consider that almost all the inflammatory disease that plague us involves nuclear factor kappa beta translocation. We can hypothesize that chondroitin would be of value in a broad variety of inflammatory conditions. What about psoriasis? This study was prompted by a dermatologist who noted that one of his patients with long-standing psoriasis got better when that patient began chondroitin sulfate to deal with knee osteoarthritis. So that led to a study of 11 subjects with moderate to severe psoriasis, mean duration 26 years, 35 to 75% of their body surface was involved, poor response to standard therapy, and they also had symptomatic knee osteoarthritis. Do the baseline studies, a skin biopsy symptom survey, treat all with 800 milligrams per day of chondrosan. Now, in Europe, chondroitin is a registered drug of known purity, and it's regulated. You need a prescription to get it. In other words, chondroitin sulfate is going to be more expensive in Europe, but you know exactly what you're getting. In the United States, chondroitin cannot be patented because it's extracted from animals and you cannot patent that. So it's over the counter in the United States, so it's going to be less expensive, but then we don't know exactly what we're getting in chondroitin sulfate from different suppliers. So they all got 800 milligrams per day of chondroitin sulfate, and you repeat the baseline assessment at 2 months. Now, I don't really understand how to look at these skin biopsies, but the epidermal thickness decreased with chondroitin. The stratum basale to stratum granulosum ratio decreased, as did the stratum corneum. So in other words, the skin was less thick, it was less scaly with chondroitin sulfate. The number of keratinocytes, those are the cells that make up the pathologically thickened skin, decreased with chondroitin sulfate. Dramatic clinical improvement in 10 out of 11. Now, these patients have been stuck for many years with psoriasis. They go on chondroitin. Dramatic clinical improvement in 10 of 11. Only one didn't get better. Full resolution in 1 of the 11. And then signs and symptoms returned after chondroitin sulfate was stopped. There's a psoriasis disease activity index that got better. So chondroitin worked by blocking nuclear factor kappa beta translocation, which played a role in the inflammation underlying psoriasis. And chondroitin sulfate blocked that, and the skin condition improved while the patients were taking the chondroitin. Inflammatory bowel disease, an autoimmune condition, also involves nuclear factor kappa beta translocation. Let's look at 37 subjects with symptomatic osteoarthritis and inflammatory bowel disease in remission. 18 had Crohn's disease involving the small bowel. 19 had ulcerative colitis involving the large colon. Mean duration of disease was 13 years, 70% female, mean age 60. And most of them were on maintenance immune modulation, immunosuppressive therapies. Baseline symptom survey, treat all these 37 subjects who are currently in remission with 800 milligrams a day of chondrosan. Repeat the symptom surveys periodically over 1 year. No significant side effects. One of the 18 ulcerative colitis patients experienced a mild flare at the 6-month visit. None of the Crohn's patients experienced a flare. So the relapse rate was 3.4% per patient per year. And historically at this time, the relapse rate should have been about 25%. So adding chondroitin sulfate to standard therapy helps maintain remission in patients with inflammatory bowel disease. A similar study was done with fish oil that I present in another presentation, and fish oil also maintained remission in patients with inflammatory bowel disease. Why? Because both fish oil and chondroitin sulfate have anti-inflammatory characteristics. They work at different mechanisms, and we would anticipate that their effects would be synergistic. Their osteoarthritis also got better. Their osteoarthritis pain score fell from 5.9 to 3. Their Crohn's disease activity index and their ulcerative colitis activity index remained low and stable throughout the study. So you're lowering inflammation in the joint and in the bowel wall. You're getting benefits in osteoarthritis, and you're maintaining remission in inflammatory bowel disease. Chondroitin sulfate in DIO, diet-induced obesity-related inflammation and atherogenesis. DIO mice, you take wild-type normal mice and feed them a 60% fat diet, they become diabetes. They have a diabetes phenotype, the DIO mice. So you treat them over 6 days with intraperitoneal bovine chondroitin sulfate. It was 63% 4, 31% 6, 1,000 milligrams per gram per day, or intraperitoneal saline control. Let's look at inflammatory cytokines. Interleukin-1 beta, tumor necrosis factor alpha were lower in the animals that received chondroitin sulfate. Serum endothelial chemokines, KC, RANCE, and TARC. These are chemokines that are elaborated from the vascular wall to pull in white cells. I don't know what TARC stands for, but it doesn't not sound like a good thing. I do not think I would like high levels of TARC. I think I'd rather take chondroitin sulfate. If you look at deposition of macrophages and the initiation of plaque, fatty streaks in the vascular wall, it was dramatically attenuated by chondroitin sulfate. Now, a related study, we're going to take human coronary endothelial cells, the cells lining our arteries, incubate them for 24 hours with chondroitin sulfate, prednisolone, which is another version of prednisone, corticosteroid, or vehicle. Then add in tumor necrosis factor alpha, 3 nanograms per milliliter for 16 hours. We know that TNF-alpha is going to cause nuclear factor kappa beta translocation and an inflammatory storm. Let's look at supernatant endothelial chemokines that are elaborated from the cells. GRO-A, MCP1, RANCE, and IP10. These are inflammatory chemokines that would be elaborated from the endothelial cells to say, hey, I got a problem. I want white cells to come in. So with the TNF, all these chemokine elaboration increases, and you can see that chondroitin sulfate did as good, if not better job, than did prednisolone in blunting their elaboration in response to TNF-alpha, because both prednisone and chondroitin sulfate will block nuclear factor kappa beta translocation and block sulfate. Interleukin-6, interleukin-8, their production is blunted. C-reactive protein is blunted. Extracellular related kinase, I'm sorry, we already went over this slide. I have a double in there. Nuclear factor kappa beta translocation is blunted. Now we'll look at human monocytic line THP cells. These are activated mononuclear cells, macrophages. Incubate for 24 hours with prednisolone or vehicle. Stimulate with tumor necrosis factor alpha for 16 hours. We know that TNF-alpha will lead to nuclear factor kappa beta translocation and elaboration of more cytokines. So TNF-alpha leads to elaboration of more TNF-alpha. This is blunted with prednisone and chondroitin. Interleukin-1 beta, interleukin-23 other inflammatory cytokines. TNF upregulates their expression. This is blunted with prednisone and with chondroitin sulfate. Another study, these human monocytic cell lines incubate with chondroitin, prednisolone, or vehicle, then stimulate with PMA, which is a non-specific, non-pathologic mitogen. You still see increased elaboration of TNF-alpha, interleukin-18. It's blunted with prednisone, but it's not blunted as well with chondroitin sulfate. So the message here is that chondroitin sulfate seems to blunt pathological, inappropriate translocation of nuclear factor kappa beta, but not appropriate translocation. So it's not going to inhibit our ability to fight infection. In our first discussion, we talked about how colchicine blocks generation of NADPH oxidase in response to pathologic stimuli such as crystalline uric acid or crystalline cholesterol, but it doesn't block NADPH oxidase activity in response to a physiologic stimulus. So colchicine and chondroitin sulfate seem to block pathologic inflammation, but they would not block an appropriate inflammatory immune response to a real threat such as infection. the ability of these mononuclear cells to migrate was increased by incubation with TNF-alpha. And of course, the more mobile the cells are, the more they're going to move within the artery wall and engulf lipids. And this was blended with prednisone and chondroitin sulfate. In diabetes-induced obesity and in stimulation with TNF-alpha, you generate a pro-atherosclerotic phenotype. Endothelial chemokines are elaborated, inflammatory cytokines are generated in the endothelial cells and the mononuclear cells via nuclear factor kappa beta translocation, enhanced mononuclear migration and endothelial infiltration, and chondroitin sulfate blocks this pro-atherosclerotic phenomenon in vitro and in vivo. And in this animal model, blunts diet-induced atherosclerosis. Chondroitin sulfate in experimental atherosclerosis and autoimmune arthritis. This would be a model of human rheumatoid arthritis and atherosclerosis. We're going to take genetically normal New Zealand white rabbits and create an autoimmune arthritis and atherosclerosis model. You're going to feed the animals an atherogenic diet, 2% cholesterol and 6% peanut oil. You're going to create an endothelial lesion. 2 weeks later, you're going to infuse nitrogen into the femoral artery intima, and this will create a uniform lesion, and it would mimic balloon angioplasty trauma. This is used to study therapies to see if they will help blunt restenosis following balloon angioplasty. So you're going to damage the intima and create a lesion. Then you're going to immunize them against ovalbumin. So you're going to administer subcutaneous ovalbumin with an adjuvant on 2 times, and that's going to create a Th1, Th17 immune response to ovalbumin and abnormal protein. Then, after you've immunized the animals to ovalbumin, you're going to carry out 4 knee joint injections of ovalbumin, and then you're going to mount an immune response, an inflammatory immune response in the joint to the ovalbumin, and that would be similar to rheumatoid arthritis. So you have this experimental model, and in some of the animals, you're going to treat them with chondroitin sulfate, 100 milligrams per day, intraperitoneal, begun 1 week before the endothelial lesion was generated. Will chondroitin sulfate protect these animals against autoimmune and diet-mediated atherosclerosis? Will it protect against restenosis following endothelial injury that would mimic balloon angioplasty? So 15 had autoimmune arthritis and atherosclerosis, 10 the same model with chondroitin sulfate therapy, 15 control animals, normal diet with sham procedures. So with this poor diet, cholesterol rose, and chondroitin sulfate lowered cholesterol a little bit in this animal model, probably by blocking inflammation, by blocking nuclear factor kappa beta translocation. Then there'll be less upregulation of HMG reductase, less elaboration of cholesterol. HDL fell with the bad diet, chondroitin sulfate didn't help. Triglycerides rose with the bad diet, and here chondroitin sulfate helped a little. C-reactive protein and interleukin-6 inflammatory mediators, Th1 cytokines increased in this animal model of autoimmune arthritis and atherosclerosis, and this elaboration was blunted with concomitant treatment with chondroitin sulfate. Nuclear factor kappa beta translocation occurring in the mononuclear cells in our blood. So there's going to be systemic inflammation, nuclear factor kappa beta translocation blunted with colchicine, cyclooxygenase 2 mediates the generation of inflammatory mediators. It is upregulated in this animal model, and this is blended with chondroitin. MCP1 is a chemotactic molecule that is elaborated by the activated endothelial cells to pull white cells in. It's activated in the animal model of autoimmune arthritis and atherosclerosis. This is blended with chondroitin. Restenosis following that intimal injury was much greater in the animals that did not receive chondroitin sulfate. The neo-intimal media ratio, a marker of restenosis lesion formation, was 2.5 with autoimmune arthritis and diet-induced atherosclerosis, and it was blunted dramatically with chondroitin. So chondroitin blunted restenosis in this animal model. If we look at at the cells within the aortic lesion, within the intimal lesion, MCP1 gene expression rose, so there's going to be greater macrophage infiltration into the arterial lesion, greater COX-2 gene expression and protein expression. This is all blunted with chondroitin sulfate within the arterial lesion. The neointimal media ratio, which reflects restenosis, increased. Then they just looked at the percentage the aorta was covered with plaque in this diet and autoimmune-induced atherosclerosis model, and lesion representation fell from 60% to 10%. So it blunted the generation of atherosclerosis in general, and it blunted this experimental restenosis in diet-induced autoimmune disease and atherosclerosis. So let's talk about LDL proteoglycan trapping. So we have this ground substance within the intima, which is proteoglycan composed predominantly of chondroitin sulfate within the intima, to which the LDL particles can be trapped, so they're immobilized, they can't swim back out in the circulation, they can only be oxidized by free radicals generated by all the cells of the intima. Let's look at vascular wall proteoglycan content in North versus Southern China. Atherosclerosis is more prevalent in Northern versus Southern China. We're going to examine human coronary arteries aged 15 to 39 of individuals who died of an accidental death in Beijing, which is North China, and Gansu, which is Southern China. We're going to characterize vascular wall proteoglycan as heparin sulfate, chondroitin sulfate, dermatin sulfate, chondroitin sulfate. Now, in Southern China, where cardiovascular disease is less prevalent, we see a higher level of vascular wall proteoglycan, but lower levels of chondroitin sulfate. Chondroitin sulfate is the proteoglycan that is sticky. So lower levels of chondroitin sulfate proteoglycan in South China may explain why the prevalence of atherosclerosis in Southern China is less than in Northern China, that has a higher representation of chondroitin sulfate proteoglycan within the vascular wall. Human coronary arteries aged 15 to 39 following accidental death. We can describe it as normal vessels, vessels with very early atherosclerosis as fatty streaks. So macrophages come in, engulf oxidized LDL, and they die, and this produces the fatty streak. Intermediate lesions and then mature atherosclerotic plaques. This will be a normal vessel. This is a vessel with a plaque. These are crystals of cholesterol with fibrous material. There'd be infiltrates of mononuclear cells, etc. So you're going to stain for chondroitin sulfate proteoglycan, smooth muscle cells. Now, as the plaque thickens, smooth muscle cells will proliferate and enter the vascular wall to form up the plaque, and beta lipoprotein, which is another term for LDL. Now, so in the normal vessels, there's low levels of chondroitin sulfate proteoglycan. In the fatty streaks, the initial manifestation of atherosclerosis, you see triple the elaboration of chondroitin sulfate proteoglycan in the fatty streak. In the adjacent vessel wall that is normal, you see some increase in proteoglycan. That's because this area, while not abnormal, is on its way to becoming abnormal because this patient has risk factors for atherosclerosis. As we go to intermediate lesions in plaque, we see a lower percent representation of chondroitin sulfate proteoglycan in the vascular wall. This isn't because there's less proteoglycan, it's because the plaque is now composed of smooth muscle cells and mononuclear cells, so there's lower relative representation of proteoglycan within the vascular wall. But the point here is that as we develop atherosclerosis, the elaboration of chondroitin sulfate proteoglycan increases. It's involved in lipid trapping, which is necessary for atherosclerosis to occur. This is in the intima region, the endothelial cells, in the media, which is the vascular smooth muscle. We also see increased representation of proteoglycan. All the cells of the vascular wall in the situation of atherosclerosis start making proteoglycan, the cells of the intima and the cells of the media. Increased proliferation of chondroitin sulfate characterizes and mediates atherosclerosis. So there's an increased representation of chondroitin sulfate in disease segments of the vascular wall. It's secreted by vascular smooth muscles with a synthetic phenotype that are infiltrating the vascular wall and adding to the plaque. It co-localizes with LDL because the LDL proteoglycan complex is avidly taken up by macrophages and vascular smooth muscles. These cells generate proteoglycan composed of chondroitin sulfate, and the LDL is tethered to that. The macrophages generate chondroitin sulfate, and that mediates their attraction and uptake of the LDL and oxidized LDL molecules. Glycosaminoglycan content and local atherosclerosis susceptibility. We're going to take normal human arteries, people who die of an accidental death between 25 and 35. We're going to look at the abdominal aorta, thoracic aorta, iliac artery, and the pulmonary artery. Now, the first vessel to be involved with atherosclerosis is the abdominal aorta. Then the thoracic aorta, then the iliac artery, which serves the leg, and the pulmonary artery rarely has atherosclerosis. It is protected. We're going to quantify vascular wall glycosaminoglycan content. You can see that in the abdominal aorta and thoracic aorta, regions of greater vulnerability to the atherosclerosis, there's a greater representation of glycosaminoglycan. So the vascular wall will be stickier for LDL. They have less collagen, but more glycosaminoglycan than the iliac artery and the pulmonary artery, which are relatively protected from the development of early atherosclerosis. You can determine what percentage of the glycosaminoglycans are hyaluronic acid, heparin sulfate, dermatan sulfate, or chondroitin sulfate in these vessels, and you can plot this out. And this is sort of a busy slide here, but the key finding is that in the abdominal aorta and the thoracic aorta, which are more susceptible to atherosclerosis, there's a greater representation of chondroitin 4,6 sulfate than in the iliac artery and the pulmonary artery that are less susceptible to atherosclerosis. If we look at the disaccharide composition of the glycosaminoglycans in the abdominal aorta and the thoracic aorta, they have more 6S. 6S chondroitin sulfate binds more avidly to LDL than does 4S, than does non-sulfated chondroitin sulfate. So an increased elaboration of 6S chondroitin sulfate mediates the increased susceptibility of the abdominal aortic and the thoracic aorta to early atherosclerosis. Aortic segments with greater 4 and 6 chondroitin sulfate are at increased susceptibility to cardiovascular disease, and they have a greater ratio of 6S to 4S. So 6S chondroitin sulfate content rises with age, 6S content rises with atherosclerotic involvement, 6S binds LDL more avidly than 4S, proteoglycan-bound LDL is more avidly taken up by macrophages versus LDL that is not bound to proteoglycan. Macrophage proteoglycan dynamics. We're going to take murine macrophages. They're activated, they're mobile, they're ready to elaborate proteoglycan and bind to LDL and oxidize LDL. Will determine the content of the cell membrane proteoglycan. 80% is chondroitin sulfate, 20% is heparin sulfate. Will determine the degree to which the macrophage membrane proteoglycans bind to lipids. 73% of the proteoglycans on the cell membrane of the macrophage will bind to LDL. Now, the LDL protein has a positive charge, chondroitin sulfate has a negative charge, particularly highly sulfated or 6-sulfated chondroitin sulfate, so there's an electrostatic interaction. Now, oxidized LDL loses its charge, it's negative, so there's no longer an electrostatic attraction, but nonetheless, 57% of the macrophage membrane proteoglycans will bind to oxidized LDL. So the proteoglycans bind to LDL, native LDL, and to oxidized LDL. Now let's measure the binding of macrophage membrane proteoglycan to oxidized LDL. You incubate LDL with copper and it will become oxidized. With or without pre-incubation with increasing or competitive levels of exogenous chondroitin sulfate and heparin sulfate. So if the membrane-bound chondroitin sulfate and or heparin sulfate binds to oxidized LDL, and we throw in increasing levels of exogenous chondroitin or heparin sulfate, that should interfere with binding of the macrophage membrane proteoglycan to oxidized LDL. We find that exogenous heparin sulfate has no effect, but exogenous chondroitin sulfate will block binding of macrophage proteoglycan to oxidized LDL. Chondroitin sulfate, but not heparin sulfate, is involved in macrophage oxidized LDL binding. Chondroitin sulfate competitively inhibits the binding of oxidized LDL to macrophage proteoglycan. Now, so if we supplement with chondroitin sulfate, we should inhibit this binding of LDL and oxidized LDL to macrophage-generated proteoglycan. This is not a new concept. We talk about lipoprotein A, that's LDL surrounded by apolipoprotein little a, which is a Velcro strip. It attaches to lysine and proline within collagen of the damaged vascular wall and mediates atherosclerosis. So we treat high LPA by supplementing with lysine and proline. So the LPA is going to bind to lysine and proline with the vascular wall. If the circulation is saturated with lysine and proline, the lysine and proline binding sites on the circulating LPA will be bound up with exogenous lysine and proline, and it can't stick to the artery wall. We can use the same principle here, and our theory will be that chondroitin sulfate supplementation will block LDL and oxidized LDL binding to the macrophages. In our second study, we showed those cells of the intima in tissue culture and how if you load with lipids, they will bind to the proteoglycan and you can stain them with the Sudan stain. But if you then throw in exogenous chondroitin sulfate, the lipids will be washed out because the lipids are binding to chondroitin sulfate. Supplemental chondroitin sulfate will block LDL and oxidized LDL binding to macrophages. Another study, we're going to take macrophages, pre-treat with heparinase, which degrades heparin sulfate on the macrophage cell membrane, or chondroitinase, which degrades chondroitin sulfate on the macrophage cell membrane. We're going to measure binding of membrane proteoglycan to oxidized LDL. If you degrade heparin, the binding actually increases. The heparin sulfate inhibits binding. If you degrade chondroitin sulfate, the binding decreases. It's chondroitin sulfate, but not heparin sulfate, that is involved in macrophage LDL, oxidized LDL binding. Another study, we're going to take Chinese hamster ovarian cells, wild type or mutant cells that do not have either heparin sulfate, they do not have heparin sulfate and have more chondroitin sulfate, another mutant cell line where heparin sulfate and chondroitin sulfate are both absent. Measure binding of membrane proteoglycan to oxidized LDL. If you do not have heparin sulfate, which inhibits binding, but you're high in chondroitin sulfate that promotes binding, you'll get greater binding. The mutant cells that lacked heparin or chondroitin sulfate did not bind. The ability of the macrophage to incorporate the oxidized LDL into the macrophage to cause a foam cell, to initiate atherosclerosis, to cause the fatty streak, was enhanced with high chondroitin sulfate. Without chondroitin sulfate, it's inhibited. Chondroitin sulfate is involved in macrophage, oxidized LDL binding and uptake. So the cells of the intima are generating chondroitin sulfate proteoglycan. Lipids are binding to this proteoglycan. They're getting stuck. They can't swim out back to the circulation. The macrophages is generating chondroitin sulfate proteoglycan that mediates binding of the macrophage to LDL and oxidize the LDL. So therefore the LDL gets stuck, it gets oxidized, it gets taken up by the macrophages. We get foam cells, we get the beginning of the atherosclerotic process. Here we're going to incubate LDL with increasing levels of copper sulfate to get LDL oxidation, and you would see a rise in myoaldehyde or a rise in lipid peroxides. And when you oxidize the LDL, it has an increasing negative charge. Now, native LDL has a positive charge. Oxidized LDL has a negative charge. You'll measure binding of membrane proteoglycan to LDL and oxidized LDL. As you begin to oxidize the LDL, it binds more rapidly to the macrophage proteoglycan, whereas heavily oxidized LDL does not. But there's other mechanisms through which oxidized LDL will be incorporated into the macrophages, such as the scavenger receptor. But the message here is that lipid oxidation enhances incorporation of the lipid particles into the macrophages to cause the formation of foam cells and initiate the atherosclerotic process. Another study of murine-derived macrophages, you're going to incubate them with angiotensin II which activates NADPH oxidase to cause oxidative stress. So you're now going to oxidize the macrophages. Now the LDL phospholipids can be oxidized. The cell membrane of the macrophages has phospholipids. They in turn can be oxidized. So we're going to oxidize the macrophages. We'll determine macrophage lipid oxidation and macrophage membrane proteoglycan and glycosamine glycan content. So as you incubate the macrophages with increasing levels of angiotensin II, greater upregulation of NADPH oxidase, more superoxide generation, of course, macrophage lipid peroxides will increase. So the macrophage membrane is getting oxidized. And the oxidized macrophage membrane makes more proteoglycan and makes more glycosamine glycan. So under oxidative stress, you oxidize your lipids, you oxidize the cell membrane of the macrophage. They respond by making more chondroitin sulfate, proteoglycan, making them stickier for LDL and oxidized LDL. So we're going to determine which glycosamine glycan species is upregulated by oxidative stress. Of course, it's chondroitin sulfate, the sticky one, not heparin sulfate. So we feel that chondroitin sulfate is of great value in cardiorheumatology. And we've presented studies showing that it's of benefit in atherosclerotic vascular disease, psoriasis, and osteoarthritis. It's likely of benefit in inflammatory bowel disease, gout, and in other autoimmune conditions characterized by Th1, Th17 skewed immune dysregulation. What is the mechanisms of benefit? Nuclear factor kappa beta translocation. Most importantly, LDL and oxidized LDL binding to intimal and macrophage proteoglycan is blunted. It likely has a weak anticoagulant effect and some effect on lipids. There's no risk. It does not affect insulin sensitivity. It does not interfere with the metabolism of drugs or other nutraceuticals. The key questions are which source? Bovine, porcine, or marine? What is the best dose? We don't really know. Which vendor should we use? Now, in Europe, we could use Chondrosulf and other products generated by the biopharmaceutical industry, and these are of known quality and efficacy, but of course they cost more. So let's look at Chondrosulf bioavailability. 20 healthy volunteers, you administer 4 grams of Chondrosulf. This is bovine-derived chondroitin sulfate, 55% 4S, 40% 6S, 5% non-sulfated. They have a sulfate to disaccharide ratio of 0.95. The greater that ratio, the more powerful the chondroitin sulfate will be in inhibiting binding of LDL and oxidized LDL to proteoglycan and macrophage LDL. Molecular weight is 25 to 30,000 Daltons. You'll measure levels of chondroitin sulfate in the circulation over the 48 hours following administration of a single dose. Now we have a little bit of chondroitin sulfate in our circulation all the time. You take the Chondrosulf, it spikes, and then the level attenuates after a period of time. You can determine the degree to which the chondroitin sulfate is sulfated, whether it's non-sulfated, whether it's 6S or 4S sulfated. Now, so if you take the Chondrosulf, the amount of chondroitin sulfate in your circulation rises. In the unsupplemented subjects, most of the chondroitin sulfate in the circulation was unsulfated. 4 hours after administration of Chondrosulf, there's less that's unsulfated. You see more 4-sulfated, and now you see 6-sulfate, and 6-sulfate will be the most biologically active form of chondroitin sulfate with respect to inhibiting lipid binding of LDL and oxidized LDL to the vascular wall. So at baseline, most of the chondroitin sulfate in the circulation is unsulfated, and after you administer Chondrosulf, the percentage that is unsulfated falls. The percentage that is 4-sulfated will rise because Chondrosulf has 4-sulfate, and we have nil 6S 6-sulfated chondroitin sulfate in our circulation. Under usual conditions, if you take Chondrosulf, it will rise. The sulfate to disaccharide ratio, which you want to be high, rises with Chondrosulf administration, and then it falls. Now, we don't have Chondrosulf here in the United States, so it fell upon the R.H. Poling Metabolic Institute to determine the best approach to utilizing chondroitin sulfate in our patients. So Dr. Poling and I and the rest of the brain trust at the R.H. Poling Metabolic Institute were given this task, and we received a grant from the University of Michigan and from the Clinton Global Initiative because Poling's in tight with the Clintons. And if you want to support our work, you could donate to the University of Michigan, which will pass the money on to us, or you could donate to the Clinton Global Initiative, and you can be comfortable that at least $5 out of every 100 that you donate to the Clintons will be given to us or some other worthy cause. So the Poling Institute has been tasked not just with finding the best source of chondroitin sulfate, but we have another problem in the Midwest, and that is the big-headed carp threat. So these carp are swimming up the Mississippi. They threaten to get to the Great Lakes, and we have a big problem here. These huge fish, people are starting to act a little funny around the carp, so we need to come up with a way of containing the carp threat. So Dr. Poling and the Brain Trust was tasked with finding a biological solution to this problem. So Dr. Poling, in his wisdom, decided to solve both problems in one fell swoop. So what we do, we have these special laser guns, and we hit the carp, and we don't kill them, but we stun them. And then we pay these guys to haul the carp out of the rivers, and then Dr. Poling will extract the cartilage from the carp and process it, and we're now marketing it as Dr. Poling Laboratories Carpillage. 1,000 milligram capsules. We're going to make a killing here. We're going to corner the market in chondroitin sulfate sales in the United States. And of course, you know, I just made that up. So standard cardiology is all about supply demand, fixed blockages. It's about anatomy. It's not about biology. If we want to prevent and stabilize cardiovascular disease, we want to deal with risk factors, the abnormalities in our vascular biochemistry and cell biology that causes this disease to develop and progress. And of course, oxidative inflammatory stress are the key driving forces. Oxidative stress is perceived by our body as infection, so we're going to get an inflammatory response, endothelial activation, immune dysregulation, hyperlipidemia, hyperglycemia. Roberts's rules of intimal disorder, dysfunction in any one foci will affect all the others. If we have oxidative stress, everything else is going to go wrong. And Poling's postulate, correction at one foci will favorably affect all the other foci. We've certainly learned how to blunt oxidative inflammatory stress. We've seen how if we block oxidative inflammatory stress, endothelial function, hyperlipidemia, hyperglycemia will attenuate. Colchicine works by blocking NLRP3. NLRP assembly is blocked in response to frustrated phagocytosis of crystalline cholesterol or crystalline uric acid. Interleukin-1 beta and interleukin-18 are not generated. White cell infiltration of the vascular wall is blunted. No oxidative bonfire. Cholesterol crystals are functionally inert. We're going to use colchicine to abort and prevent inflammatory response to crystalline cholesterol. That's why colchicine lowers CRP. This is why colchicine, if added to standard drug therapy over 3 years, decreases adverse event rate by 75%. 3 out of 4 people that were supposed to have an event did not have an event because they took colchicine once a day. Clinical use of colchicine, that's accepted benefit in the treatment and prevention of gout, familial Mediterranean fever and Behçet's disease, pericarditis, post-pericarditis syndrome. Of the demonstrated benefits that we talked about, acute reduction in coronary interleukin-1 beta, interleukin-16, and interleukin-6, CRP reduction in chronic coronary disease, 75% event rate reduction in stable coronary disease. It blunts restenosis post-bare metal stent in diabetics. It's helpful in recurrent atrial fib post-ablation. In animal models, it blunts the initiation and progression of atherosclerosis. That may hold true in humans. Xanthine oxidase generates the lion's share of superoxide free radical in cardiovascular disease. Oxidative stress will lead to inflammatory stress that leads to endothelial dysfunction, which leads to cardiovascular disease. High uric acid, when it enters the cells, leads to oxidative stress. We get endothelial dysfunction, we get inflammation, we get cardiovascular disease. Allopurinol blocks xanthine oxidase. The heart no longer wastes precious oxygen to make superoxide, which is not helpful, and superoxide, which is deleterious and leads to endothelial dysfunction and more cardiovascular disease. So allopurinol spares oxygen, blocks superoxide generation, spares nitric oxide, preserves endothelial function. In heart failure, it increases the ratio of nitric oxide to superoxide, enhancing mechanical energetic coupling, improving the efficiency of cardiac contractility, and there's benefits in the kidney and probably all other organ systems if we block the generation of superoxide. The indications for allopurinol, clinical conditions associated with oxidative stress. Atherosclerosis, renal dysfunction. 100 milligrams a day over 7 years dramatically decreases your risk for further renal decline or for experiencing an adverse cardiovascular event. It's a value in heart failure, particularly if your ejection fraction is low and your pre-treatment uric acid level is high. It's a value in type 2 diabetes and metabolic syndrome, hypertension, at least in kids. It improves outcome in cardiovascular surgery, and of course, it's useful in gout. Nuclear factor kappa beta is our most powerful inflammation amplification pathway. It is upregulated by real threats, it's upregulated by oxidative stress, and it's blunted by chondroitin sulfate. Nuclear factor kappa beta translocation is blunted by chondroitin sulfate. With respect to pathological frustrated phagocytosis of uric acid and cholesterol crystals, chondroitin sulfate blocks step 1 by blocking nuclear factor kappa beta. Colchicine blocks step 2. We would hypothesize that their effects would be synergistic in gout and in cardiovascular disease, and they would be synergistic with allopurinol. All these drugs are traditionally used to treat gout, but we're not using them to treat gout. We're using them to lower oxidative stress, inflammation, NLRP3 activation, nuclear factor kappa beta translocation. And chondroitin sulfate blocks lipid trapping. If we can keep the LDL from trapping to chondroitin sulfate in the vascular wall, it'll swim back out into the circulation. It's less likely to be oxidized. If the lipids are not oxidized, they will not be the target of the dysregulated immune response that characterizes atherosclerosis. Thanks to Lester Morrison for bringing this information to our attention. So chondroitin sulfate, again, documented value in atherosclerotic vascular disease, psoriasis, osteoarthritis. It's likely a value in inflammatory bowel disease, other autoimmune conditions, in gout. It works by blocking nuclear factor kappa beta translocation, blunting trapping and binding of LDL and oxidized LDL to intimal and macrophage chondroitin sulfate proteoglycan. It has a mild anticoagulant effect. It has a mild lipid effect. There's no risk. And our dose right now is 1,500 milligrams twice a day. I'm giving this presentation to my colleagues in the world of integrative medicine. I'm asking them for guidance and input regarding the best source of chondroitin sulfate. Soon, we should have a very good source, a pure source of chondroitin sulfate that we can rely on, and we will find that maybe the sicker you are, we might start with a higher dose. There might be a lower maintenance dose of chondroitin sulfate. So this concludes our marathon presentation of cardiorheumatology, and here is myself and my daughter, Dr. Catherine Roberts, completing a marathon. Catherine is finishing her 4th year of training in gastroenterology. She's specializing in hepatology and liver transplantation, and when she completes her studies this summer, Major Roberts will be one of 4 hepatologists in the U.S. Army. So you can look forward to a series of lectures called cardiohepatology. So what I'm going to do now is scroll through all my references. If you want to read these are references on colchicine, page 1, page 2, page 3. We have the references on allopurinol, page 1, page 2, page 3, page 4, page 5, page 6. I read a lot on allopurinol chondroitin sulfate references, page 1, page 2, page 3. And that concludes our presentation on cardiorheumatology. I thank you for your attention.